Hey guys! So in this lecture we're going to talk about gas exchange. So there's going to be two parts to this. We have this first part, which is going to talk about mechanical ventilation, respiratory failure, and acute respiratory distress syndrome. And then in another lecture we'll talk about like things that can happen, more like chest trauma, so like pneumos, chest tubes, things like that. So this is just part one. So let's first talk about mechanical ventilation. What is ventilation, right? Ventilation is just the movement of air in and out of the lungs. Okay, so that's simply what ventilation is, pretty simple. Okay, so the clients that are going to need your mechanical ventilation typically are going to be either during surgery, if they're going to need more oxygenation of their blood, they might need to be resting their respiratory muscles, so maybe, again, they've had that pneumonia or ARDS that we're going to talk about, and we're just trying to give all their respiratory muscles a chance to heal. Okay. You also might see them, people who are in comas, overdoses, inhalation injuries, definitely shock, all right, late stage COPD, you're going to need mechanical ventilation. All right, so there's all kind of reasons that someone would be ventilated. Okay. Our mechanical ventilators are positive or negative pressures, and this helps maintain the ventilation and oxygenation, or oxygen delivery, excuse me. So some of the lab values that we're going to be assessing as nurses are obviously everything that goes into those ABGs, right? So we're going to be looking for decreased PaO2, maybe increased arterial CO2, definitely looking for persistent acidosis, right? And then, of course, we're going to always assess our airway first. Right? So let's get more into different types of ventilators. Alright, so we have positive pressure ventilators, and this is the type that you're going to really see used most often. We don't really use a whole lot of negative pressure ventilators, mostly because our lungs are already a negative pressure system, right? So it wouldn't really make a lot of sense. So typically most of them are going to be positive pressures. And we have volume cycled and pressure cycled. Okay, so in volume cycled, you have a constant volume on inspiration, and then your pressure can be variable depending on the expiration. Okay, and then pressure cycle is going to be the opposite. So you have a volume that's dependent on the airway resistance and compliance. So different types of add-ons for our ventilators, and we're going to talk about the different modes, but we definitely can have different settings that helps the modes. And one of them is high-frequency oscillating support. Okay, and this is really a high respiratory pressure and rate. It's kind of like a pulsing machine. So you can see this oxygen pulsing to the airway and helps opening up those alveoli. Okay, so these typically are in patients that are super, super sick. Septic shock patients, any type of late stage ARDS, right? So that's when oscillators are going to be seen. So it's really like this large machine, and it does a lot of vibrating. So if you kind of compare it to like your chest, I say chest vests, but the machines that break up all the mucus for our CF patients, it's almost kind of like that, except it's just constantly pushing pressure into the thoracic cage. Okay. But the problem with this is if we have too much pressure in that cage, we can cause things like barotrauma, and that's never a good thing. Okay. We also have non-invasive ventilator modes, and those are CPAP and BiPAP. So our CPAP is that continuous positive pressure versus the bilevel positive pressure. Okay, so we have both of them require our patients to breathe on their own, and they can have like an independent control, either inspiration or expiration. Okay, so problems that people can encounter with each of these, if you have a volume cycled, remember that's just volume is constant and pressure is variable, this can cause barotrauma, okay, and that's due to the force requirements on inspiration. And then problems with the pressure cycle is if you have a compromised ventilation due to inadequate tidal volume. Okay, so remember that pressure cycle has a volume dependence, so it's either going to increase or decrease depending on airway resistance and compliance. So if they don't have a well-working airway or alveoli, they're not going to get enough oxygenation. All right. So ventilator modes. Right. So this is kind of the how of mechanical breaths. So there's all kinds of modes. The most likely ones you guys are going to see out in the field are going to be the CMV and SIMV. Right, so continuous mandatory ventilation, or CMV, it has a preset volume and rate, so your patient cannot take spontaneous breaths. Okay? The machine does everything for them. So the population that you're going to see this most with is definitely like during surgery. Okay, so anesthesia, general anesthesia, you're going to be under continuous mandatory ventilation. Okay, assist control is kind of like CMV, but you can allow the patient to start breathing over it. Okay, so it's kind of like a step down. Right. So our IMV and our SIMV, right, these are going to be kind of a combo of a preset and spontaneous. But your preset intervals and volumes, you have a preset interval and volume so that the client can try, and then the machine's still going to use its preset volumes. Okay, so there's not really any fighting. So that synchronized, the difference between that intermittent and synchronized is we have different intervals preset with intermittent versus synchronized. The client can take those spontaneous breaths and the ventilator's going to adjust to it. Okay, so both of them allow your patient to breathe on their own, kind of setting the preset and kind of setting the rate. But if anything happens to where they're not breathing enough, your ventilator will kick in and do the work for them to the presets. Alright, so the last two are actually not ventilator modes, but they're kind of ventilator support. So first we have pressure support. And pressure support is, it kind of lets the patient breathe on their own, and the machine's going to apply extra pressure. Okay, so we have to kind of assess and look at the needs to adjust the rate and the tidal volumes based on how much pressure they're getting. So remember, anything with pressure support, we're going to have, we could have problems with like barotrauma and things like that. So you don't want to overdo the pressure. Now, PEEP is going to be your best friend. So PEEP's that positive end expiratory pressure. Right, so PEEP is really to help open up those alveoli. Again, you're going to see PEEP forcing that end expiratory pressure into the lungs, opening the alveoli, and fixing things like pneumonia and ARDS and ARF. But PEEP does increase thoracic pressure. So if you have that increase of your thoracic pressure, this could also lead to a decrease in your preload. Okay, so think about all that pressure in your thoracic cage. It's going to start to lean against your cardiac vessels, okay, your pulmonary and cardiac vessels, and that could decrease your preload. So PEEP can actually decrease preload, which decreases our blood pressure, which decreases our cardiac output. So we really want to watch out for that. Alright, so let's do a nursing process for mechanical ventilation. Right. So assessment, anything you need to assess with mechanical ventilation is obviously going to have to do with the respiratory system. Right. So you're going to be looking at everything. Respirations, comfort level, definitely looking our ventilator, looking for alarms. Right? So when we think about alarms, we have to look at low pressure alarms and high pressure alarms. So those high pressure alarms are typically going to go off when the patient is biting or occluding the tube. Okay, so that's the most common reason, is the patient's biting the tube. But it could be occluded for any reason, but that's what's going to set off your high pressure. Your low pressure alarms are going to be when the tube gets disconnected somehow. Okay. But when we look at assessment of the patient, definitely listening to lung sounds, watching respirations. We're going to look for increased work of breathing, so increase of those accessory muscles, diaphoresis, things like that. Some diagnoses for mechanical ventilation could be gas exchange, inadequate gas exchange, improved gas exchange. Take your choice. Lots of different diagnoses for respiratory issues. So our planning and implementation is really when we're going to think about what can go wrong with our mechanical ventilation. Right? So things that can go wrong is that kind of what we already talked about, right? So barotrauma, a pneumothorax, kinks and biting of the tubes, right? Dislodging of the tubes, when people actually extubate themselves. That is a problem, right? And definitely apnea. So we're going to be looking for all of these things and planning ahead. So our evaluation, obviously, the patient didn't extubate themselves, right? So we're hoping the goals of the oxygenation and ventilation are met, and hoping to wean these people off of mechanical ventilation. So those are our goals. So there are 3 different stages for weaning of mechanical ventilation. Right? So first we're going to wean from the mechanical support, then we're going to wean from airway support, and then from O2. Okay? So remember that that mechanical support, trying to wean things like PEEP, okay, things like pressure support. Then weaning the airway support, obviously seeing if we can do ventilator trials, so we might lower the respiratory rate and see if they can breathe over it. And then definitely O2. So when I think about weaning O2, I'm not really talking about just regular oxygen. For mechanical ventilation, you're looking at FiO2. Okay, so FiO2 is like the concentration of oxygen molecules in the air. So the FiO2 of room air is going to be that 21 or 24%. So you'll see that different modes of ventilation will have different FiO2 depending on the need of the patient. So it could be anywhere from 40% all the way up to 100. Okay, so usually the higher the FiO2, the worse off the patient is at that time. So when do we want to start thinking about vent weaning? Well, again, it's going to come down to your assessment, right? So how are they doing hemodynamically? Is their cardiac output good? Is their blood pressure good? How are their ABGs? Okay? Looking at respiratory, are any of their medical issues resolving? So if they've had sepsis or ARDS, is it starting to heal? So these are all things we're thinking about. And then of course psychosocial support, definitely looking at the family. Your patient's most likely going to be sedated, so they still can hear you, so make sure you do talk to the patient too, but it could be hard on the family depending on if we're weaning them terminally or if we're trying to get them off. Either way, it's going to be a challenge for them. Alright, some medications. Right. You're going to see all kinds of different medications when someone is on mechanical ventilation. Typically we have propofol, that's like our big guy. We can also use Versed, we can use fentanyl. Well, there's usually a mix of all 3. Okay, so you want to keep them sedated and definitely pain-free. Ativan can be used kind of in the short interim, right? And then you might see some neuromuscular blocking agents. So you might see those in cases of like the oscillator. So you're going to want to kind of have a nerve block or even a paralyzing agent for people on that, because it is such a harsh machine. Okay? So they do need to remain still and remain very, very sedated. But really it's going to depend on your hospital policy on what medications are appropriate for mechanical ventilation. Alright, so now let's talk about a couple different things that would require mechanical ventilation. So we're going to talk about acute respiratory failure, and then we're going to compare it to acute respiratory distress syndrome. Right? So remember, I like to do the what is it, how do we treat it, and what do we teach them. So first let's talk about what is it. Right? So in acute respiratory failure, this is a sudden and life-threatening problem. Okay? So it's very acute and could potentially kill your patient. So we have a deterioration of gas exchange, and the lungs are now failing to provide adequate oxygenation and ventilation. Okay, so what can cause it? Lots of things, right? Lower pH, anything under 7.35 can lead to acute respiratory failure, right? You're going to be more acidotic. Definitely being hypoxemic. Usually if you have an arterial oxygen of less than 50, you're going to lead to some hypoxemia and definitely some acidosis. And also some increase in CO2. So anything over 50, right, that's called hypercapnia. Right, so hypoxemia, hypercapnia, acidosis. Those are very, very common issues in acute respiratory failure. The VQ mismatch, this is kind of interesting. All right, so VQ actually means ventilation and perfusion. So even though Q doesn't really equal perfusion. That's what VQ means. So in acute respiratory failure and acute respiratory distress syndrome, you're going to see what we call a VQ mismatch, or ventilation and perfusion. So this is when our mechanisms for ventilation and perfusion are impaired. Right? I'm going to talk more about that VQ mismatch with our ARDS, so hang tight to that VQ mismatch. Alright, so let's think about what we assess in acute respiratory failure. What does our patient look like? Okay, obviously early signs are going to be that restlessness, agitation, anxiety. So all those earliest signs that they're not getting oxygen to their brain, right? They might be tired, they might complain of headache, right? Signs and symptoms, you might have increased heart rate, definitely increased respirations, and your blood pressure is probably going to go up at first, right? So anyone who cannot breathe is probably freaking out a little bit. So all of these things are going to increase first before they start going downhill. Right, so the lab values you're going to look at to see just how bad the failure is are going to be your ABGs and pulse ox, even though your pulse ox is kind of a later sign. So you guys remember that pulse ox is, if your pulse ox is going low, your patient has been in trouble for a long time. Okay, so never go by the pulse ox first. ABGs are going to be the best way to look at that. Okay. And of course we look at monitor respiratory status with just our normal assessment, right? Respirations, what does the patient look like, are they breathing, okay? Along with your lab values. So how are we going to treat respiratory failure? We have medical management and of course our nursing interventions, which are what you guys need to know. Okay? So your medical management, of course, is going to be your mechanical ventilation, and they're going to be with an endotracheal tube, right, at first. They might, depending on if they can't get off of that vent, they might go down to a trach. Right? So that would be our our medical management. Nursing interventions are going to be always treating that underlying cause. Okay, so we're going to find the underlying cause of that respiratory failure. Was it a near drowning causing that acidosis? Was it a COPD exacerbation gone horribly wrong? Okay, so always treating that underlying cause. But we really have to remember just our normal nursing interventions, right? How do we take care of a patient that is heavily sedated and that needs to rest their lungs, right? So we have to think about skin care, turning, definitely range of motion, and of course preventing that ventilator-assisted pneumonia, right? And the number one way to do that is with oral hygiene. So anytime you think of ways to prevent infection, you're going to think hand hygiene, but anytime you have a vent, you're going to think oral hygiene. So you're going to be in there doing some kind of oral care for those patients, whether it be every 2 hours, every 4 hours, but their mouth needs to stay clean. Okay. And I don't have a slide for it, but obviously my last favorite part of any type of system is what do we teach them? For these guys, teaching is going to be more how to prevent this in the future. So if they have a chronic condition, say COPD or asthma, it's going to make sure that they're staying on top of self-care practices at home. All right. Excuse me. So let's talk about acute respiratory distress syndrome. Okay. So ARDS is different than ARF. Okay. So ARF is that acute respiratory failure, right? Acute not being able to breathe. Acute, basically it comes on fast and it can hit hard. ARDS is more like an inflammatory process, right? So this causes severe inflammation and it can lead to alveolar damage, right? So it definitely is progressive, but it can result in like pulmonary edema and death, all right? So acute respiratory distress syndrome is always a secondary illness, right? It's always from a direct injury to a lung. You might see things like inhalation. Shock is probably the most common cause of ARDS. Something I actually saw today was a pneumonia patient. So she was probably in pneumonia and then led to septic shock, right? So this is causing that severe inflammation to the lungs from that direct insult. and then it damages alveoli. So the thing about damaging your alveoli is they never get fixed. Okay, so it's very, very hard to fix these people once they've come into ARDS. All right. So this also causes a severe VQ mismatch. So remember I said I was going to talk about it more. Right, so that VQ mismatch, that ventilation perfusion, right? So this is when we have blood that returns to our lungs. It gets pumped through non-ventilated and non-working lungs. And this is going to lead to a shunting. So now our blood is trying to work with non-working alveoli, and then it leads to impaired gas exchange. Okay? So I'll say that again. So our VQ mismatch, we have blood that's come into the lungs that's not ventilated, and it leads to a shunting of this non-ventilated blood. So then we try to work with non-working alveoli, and we have impaired gas exchange. Okay? So that's that severe VQ mismatch that you see, and you see it because we have so much inflammation to the lungs and the alveoli that we cannot oxygenate our blood. Simple, right? Clear as mud. All right. In our ARDS patients, we have something called refractory hypoxemia. Right, so this is a sign that your patient's going really downhill, right? And you might see it with your ABGs, right? This is if you see a patient that has a PaO2 of less than 50 with a FiO2 setting of over 70. Okay, so if we have that FiO2 all the way up to 70% or even 100%, and we still can't get their O2 higher than 50, that person's in refractory hypoxemia, right? So they are not doing good. So the best way to fix this, of course, is increasing our PEEP and our oscillator, right? So remember I was talking about the oscillator and how it just is that very forceful positive pressure, okay? So this is the best way we can treat ARDS, right? In critical care units, you might see things like an ECMO, called a VV ECMO, and that is specifically to help the lungs repair itself. But that is in critical care areas, and we're not really going to talk about it today. But our fixing of this is definitely an increased PEEP and an oscillator, most likely. So what is ARDS going to look like? What's your patient look like? In this case, you're going to have all of those same symptoms, except you might not get that initial restlessness and anxiety because these people have been sick for a while. Okay, so remember, this is that secondary inflammation. But what you might see is that flash pulmonary edema. Okay, so you might have infiltrates bilaterally on the x-rays. You're definitely going to see hypoxemia. You might see some retractions, and you might hear some crackles. Okay, so we have this inflammation, we have all this fluid, this blood collecting in our alveoli, not being able to pump, being shunted other places, and now we're in fluid overload, okay, causing that flash pulmonary edema. So some lab values that you can see, or you can, not even all labs, right? You might have a lab that you can look at, and a couple tests that can show ARDS are going to be a BNP, echo, and a cath. Right, so a BNP, that brain natriuretic peptide, is a lab that we can use to distinguish ARDS from pulmonary edema. But the books say it's not really conclusive, but some places will still check that BNP. Alright, so how are we going to treat ARDS? We're going to treat ARDS much like you're treating acute respiratory failure. Okay? Medical management, definitely mechanical ventilation. Right? They might need that PEEP, they might need that oscillator. Okay? They're definitely going to need some medications. Okay? This is where you're going to see that neuromuscular blocker. Right? So they have to be completely knocked out and usually paralyzed for that oscillator. You're going to see vasopressors. Right? So this is to fix that hypotension from the hypovolemia. Okay? They're going to be hypovolemic because they're shunting all that blood into other spaces. Right? So think of third spacing, but in your lungs. Right? So we have volume, but we don't have it going to the places it needs to get to. Right? And then we have that added decreased cardiac output from all that PEEP that we're pushing in. So remember I was talking about PEEP earlier. And because we have so much positive pressure in that intrathoracic cage, it's putting all that pressure on those vessels, causing them to decrease our preload and decrease our cardiac output. Right? So we're going to see all kinds of medications to help fix all these things we're causing with the treatment. Right? But we always want to treat that underlying condition. Right? So same as ARF, right? We have to treat the underlying condition. If it's sepsis, they're getting antibiotics. If it's, gosh, trauma, hopefully we've done the surgery, right? It's usually going to be that secondary. Nursing interventions, exactly the same as ARF, right? We want to think about skincare, nutrition, definitely oral hygiene, and of course psychosocial support for the family. Okay, so this is going to be one of those very, very hard to treat conditions. All right, the prognosis for these patients is not good. All right, so we need to be there for those families. But that is all I have on gas exchange part 1. So I'll see you next time for the second part.